A very good day, my dear postgraduate students. Welcome to SNIP, Short Notes in Pathology. And the topic for the day is solitary rectal ulcer. Some authors call it as solitary rectal ulcer syndrome. So do not be confused. I would like you people to kindly note the nuances in this particular page. When we go to the definition, the author defines it as solitary or multiple, ulcerated or polypoid, and 4 to 10 centimeters from the anal margin. That is the definition of the lesion. And the essential features again are not always solitary. It can be more than one. Not always ulcerated. The mucosa might be intact. And not really a syndrome, it can be solitary by itself. Mucosal prolapse can result in rectal lesions. Hence, there can be a terminology called as mucosal prolapse syndrome. So, these are the different terminologies which you people should mention. And in this picture, I am finding more of a polypoidal lesion with an evidence of a congestion or probably an exudate. Coming to the histomorphology and pathology outlines is the trump card of my presentation. All the credit goes to that author whom I have quoted at the end. In this case, I am finding a polypoidal lesion. There is to some extent a fibrovascular core. I am finding an intact mucosa and the glands are to some extent well punched out. Slight variation is there and focal crowding. But however, there is no invasion of the fibrovascular core. In another instance, again there is a lesion. Obviously, it is polypoidal because I am not finding any tissue by the side. And here, there is a lot of this vasculature, some inflammatory cells. Therefore, it is a re-epithelialization that is happening in a granulation tissue. Epidemiology. It is a very rare lesion, 1 in 1 lakh per year. Third to the fourth decade, common presentations. And females are more prone than males. And the sites are rectosigmoid. Not needed of any explanation. And in this case, it is an endoscopic picture wherein there is erythema or redness that I can see, and there is an edema of the lesion along with some areas of focal ulceration. The etiology is, it is an abnormal presentation due to a weak anal or pelvic musculature. Also, rectal prolapse, intersusception, etc. can preclude to it. The clinical manifestations can be constipation, blood and mucus discharge, altered bowel habits. Then there can be other sessile serrated polyps. And this particular gene is quoted to be in loss, HMLH1 gene. The treatment will be with, as for constipation, a high fiber diet, topical steroids for the healing of the wound, and resection if required. And the histology in this case is showing a chronic inflammatory infiltrate, and there is an attempted follicle formation also. And there is a hyperplasia of the muscularis mucosa. The gross features. As we had mentioned earlier, there can be well demarcated ulcers. And they have a fairly regular margin. Look at the margin of the lesion. You can draw a line around it easily. There is a mucosal thickening, probably because of an edema. And also, there can be polypoidal lesions. Look at this adjoining. There can be polypoidal lesions and erythema or a redness, which I am seeing over here. So, these can be the gross features. Kindly go through it. The reference is this one, which I had mentioned as my trump card. Kindly go to it. All the credit goes to them. Microscopically, you find that There can be a superficial mucosal ulceration, a villiform change, that is a finger-like projection can be there. Fibromuscular hyperplasia. And look at this one. There is a fibromuscular stroma. It is hyperplastic in the sense it is pushing the glands away. And more important is there is a pattern. You find that it is a crisscross pattern that is evolving. Ectatic or abnormally dilated capillaries can be present. As in the previous slide, there can be inflammatory infiltrate and pseudomembranes can be present. So this is important. Pseudomembranes and pseudopolyps, they are all indicative of some other lesion which come under the differential diagnosis. And they can cause what is called as colitis cystica profunda. No malignancy is because of this, but it can do coexist with a malignancy. Hence, great care is needed. The differential diagnosis will be an inflammatory bowel disease. That is why we mentioned the words pseudopolyp, etc. Rectal neoplasms or bowel cancer. Chronic ischemic ulcer. Any ischemia can lead to an ulcer. And infectious lesions such as amoebiasis, lymphogranuloma, or syphilis. Endometriosis in the rectum. Colitis cystica profunda. That is what I have given over here. You find that there is a cystic distension and it is lined by an intact mucosa, though it is thinned out. And this is exactly the presentation of the colitis cystica profunda. Sometimes you can find it lower down also in the muscular layers. Idiopathic. So these are the differential diagnoses which you shall mention. A nice topic, difficult to answer, but you can score 90% if prepared. Thank you.